Usually, when a pipe in your house breaks, it just bursts, right? Like
Yeah.
it's a simple catastrophic mechanical failure.
Right. Water everywhere.
Exactly. But imagine if, instead of breaking, that pipe started to inflate, like a balloon.
Oh, wow.
And the physics of your house basically guarantee that it would never, ever stop inflating until, the inevitable happened.
That is a pretty terrifying image.
It is, and that is the terrifying reality of an aneurysm. If you, the listener, take a second and just put your hand on your stomach right now, a few inches beneath your skin is a highly pressurized pipeline.
A very critical one.
Yeah, and we expect that internal plumbing to just stay the exact same shape for our entire lives. But today's deep dive is about what happens when the rules of that plumbing completely fall apart. We've taken all your notes on the pathophysiology of this and distilled it down to the core mission today, which is understanding why vessel walls bulge, how they balloon, and ultimately why they rupture.
It really is a fascinating and honestly somewhat horrifying biological reality. We are looking at a scenario where the structural integrity of a blood vessel wall becomes compromised.
Right.
And when that happens, it creates this mechanical feedback loop that is just incredibly difficult for the body or even for medicine to stop.
Okay, let's unpack this. To really grasp how an artery turns into like a ticking time bomb, we first have to understand what actually counts as a bulge.
Exactly.
Because, a radiologist doesn't just look at an ultrasound and scribble down, hey, this pipe looks a bit wide.
Yeah.
There has to be a strict mathematical threshold, right?
There is, and it's actually quite precise. So in clinical terms, an aneurysm is a permanent, localized dilation of a blood vessel to at least 1.5 times its normal, healthy diameter.
Okay, so the baseline rule is a 50% increase in size.
That's it. For example, a normal abdominal aorta, that main pipeline running down through the center of your torso, that's roughly 2 centimeters across in a healthy adult.
Just 2 centimeters.
Yeah, roughly. So once that vessel stretches to about 3 centimeters, it officially graduates from being mildly dilated to being formally diagnosed as an aneurysm.
But the sources you brought highlight that even this strict definition gets kind of complicated based on who we're actually looking at.
Oh, absolutely.
Because saying an aorta is aneurysmal at exactly 3 centimeters seems like a really blunt instrument. The internal plumbing of a petite 5-foot-tall woman and a massive 6'5" man, they're not going to have the same starting dimensions.
No, of course not. And that biological variation is actually driving a major transition in vascular medicine right now.
Oh, really?
Yeah. Historically, the field relied on those flat, absolute cutoffs, like the 3 centimeters, simply because it's an easy clinical shorthand. It's, quick to memorize.
Makes sense.
But modern vascular societies are strongly pushing for what we call size-indexed definitions.
Meaning you calculate the dangerous diameter relative to the size of the person's body.
Precisely. You calculate it based on their body surface area. So a 3-centimeter aorta in that 6'5" man might represent a totally normal variance or maybe just a very mild stretching.
Right.
But in that 5-foot woman, a 3-centimeter aorta could represent a massive, deeply dangerous stretching of her normal tissue. Calibrating to the population makes the diagnosis mathematically precise for the actual individual standing in front of you.
That makes total sense. Speaking of the physical tissue, there is a crucial distinction in the structural integrity of these bulges in the notes. They draw a hard line between a true aneurysm and a pseudoaneurysm.
Yes, very important distinction.
And reading through the mechanics of this, I kept picturing, like, a car driving on a really bad highway. Is a pseudoaneurysm basically like a tire blowout that's only being temporarily held together by the thick mud wrapped around the axle?
That is a phenomenal way to visualize it, actually.
Oh, thanks.
To understand the difference, you have to know that a blood vessel isn't just a single flat tube. It's built in 3 distinct layers. You have the intima on the inside, the media in the middle, and the adventitia on the outside. A true aneurysm involves all 3 of those layers ballooning outward together.
So the wall is entirely intact, it's just stretched out of shape.
Right. The tire is bulging, but the rubber hasn't punctured yet.
Got it.
But a pseudoaneurysm, or a false aneurysm, isn't a structural stretching at all. The vessel wall has actually already torn.
Wait, it's already broken.
Yes. The high-pressure blood is actively leaking out of the pipe, and the only thing holding that pressurized blood inside the body is a makeshift wall of clotted tissue and that very flimsy outer adventitial layer.
Wow. So on a quick scan, they might look like the exact same thing, just a big pocket of swirling blood. But structurally, one is a stretched pipe, and the other is a broken pipe temporarily plugged by bodily debris.
They are complete opposites structurally, and the shape of that pocket of blood matters immensely too.
It shapes like fusiform and saccular, right?
Exactly. The medical field categorizes them primarily into those two shapes. Fusiform aneurysms bulge symmetrically along the entire circumference of the vessel wall.
Like blowing up a balloon so it looks like a thick sausage.
Perfect analogy. Saccular aneurysms, on the other hand, bulge out to one side only. They look asymmetrical, like a small, round berry hanging off the side of a tree branch.
Okay, so that must be where the term berry aneurysm comes from,
Yes, exactly.
which is the kind we usually hear about happening in the brain.
Yeah.
But why does the shape actually matter? I mean, a bulge is a bulge, isn't it?
Well, it comes down to stress distribution. A symmetrical fusiform aneurysm distributes the mechanical stress of your blood pressure relatively evenly across the entire stretched wall.
Okay.
But an asymmetrical saccular bulge concentrates all that mechanical stress into one tiny, uneven pocket.
Ouch.
Yeah, they behave very differently. And that concentrated stress means saccular aneurysms have a highly unpredictable risk of rupturing.
Let's talk about that mechanical stress, because we have to get into the physics here. This was honestly the most mind-bending part of the research for me.
It's intense, isn't it?
It really is. The rules governing these bulges are completely counterintuitive. Normally, when you get a cut, your body heals it. When a muscle tears, it repairs itself. But an aneurysm doesn't heal. It actively, aggressively gets worse.
It does.
And it all boils down to something called Laplace's law.
Laplace's law is the absolute core of why aneurysms are so lethal. It's a principle of physics that describes the mechanics of any pressure vessel, whether that's, a submarine, a water pipe, or a human artery.
Okay.
For a cylindrical vessel, the law states that the tension on the wall is proportional to the pressure of the fluid, multiplied by the radius of the tube, and then divided by the thickness of the wall.
Okay, wait. Let's pause and break that equation down for real life, because it is terrifying once you see how it actually works.
Yeah.
So tension equals pressure times radius, divided by thickness.
Right. So two massive clinical realities immediately fall out of that equation. First is the pressure variable. High blood pressure directly, linearly increases wall tension.
Okay, more pressure pushing outward equals more tension tearing at the tissue. That part is totally logical.
Yes. And this is the primary reason why chronic hypertension is arguably the single biggest driving force behind an aneurysm growing. The harder the fluid pushes, the more tension the wall feels.
Right, but what about the radius? Because that's where things get weird.
This is the insidious part. Because the radius of the pipe is in the top half of that equation, once a blood vessel starts to widen, once its radius increases, the wall tension automatically goes up.
Even if the blood pressure stays the same.
Even if the patient's blood pressure stays the exact same, the sheer physical fact that the pipe is now wider means the tissue is under significantly more mechanical stress.
Wait, so it's a vicious circle. The wider the pipe gets, the harder the physics push against the walls, which forces the pipe to get even wider, which makes the physics push even harder.
It is a mathematical death spiral. An aneurysm doesn't stabilize. A widening vessel wall is fighting an opponent that literally gets stronger as the fight goes on.
And wait, it gets even worse, right? Because as a tube stretches out, the wall of the tube has to get thinner, like, stretching a piece of bubble gum.
Yeah.
And thickness is the bottom of the equation.
You've hit the nail on the head. As the radius increases, driving tension up, the wall thickness decreases, driving tension up even further.
Wow.
The physics compound on themselves. This is why aneurysms essentially never shrink on their own. They enter a mechanical feedback loop that just pushes them toward a catastrophic rupture.
Here's where it gets really interesting, though. If the physics guarantee that a stretching vessel will keep stretching, what actually causes the vessel wall to weaken and start expanding in the first place? Like, why doesn't this happen to every single blood vessel in our bodies?
That's a great question. To understand the initial weakness, we have to zoom in from physics down to cellular biology. An aneurysm is fundamentally a disease of the structural matrix of your tissue. We mentioned the middle layer of the artery earlier, the media.
Right, the middle layer.
That layer relies on two vital structural proteins. One is elastin, which allows the vessel to expand and recoil with every single heartbeat.
Like a rubber band.
Exactly. And the other is collagen, which acts as the rigid backbone, giving the vessel its raw tensile strength.
So the vessel wall is built out of a combination of rubber bands and steel cables.
That's exactly it. And an aneurysm forms when those specific proteins are degraded and destroyed faster than your body can manufacture replacements.
What's destroying them?
The main culprits here are enzymes called matrix metalloproteinases, or MMPs.
MMPs, which honestly sounds like something out of a sci-fi movie.
They kind of act like them too. These enzymes are released by inflammatory cells that infiltrate the vessel wall, and they essentially operate like microscopic Pac-Men, just relentlessly chewing through your elastin and collagen.
And the sources point a massive glaring finger at smoking here.
Oh, absolutely. Because smoking dramatically accelerates the cellular destruction.
Really?
Yes. Patients who smoke have measurably significantly higher levels of these MMP enzymes active in their aortic tissue. Furthermore, atherosclerosis, which is the buildup of cholesterol plaques in the arteries, actively recruits these exact inflammatory cells to the site.
So they're connected.
Deeply connected. This is a crucial revelation, actually. An abdominal aortic aneurysm and atherosclerotic heart disease aren't just two random, unrelated things happening in the body at the same time. They are deeply interconnected manifestations of chronic vascular injury.
So we have these enzymes literally chewing up the structural steel cables of the artery walls, and then Laplace's law yanking those weakened walls apart.
Yes.
For most of human history, that combination was just a guaranteed death sentence, wasn't it?
It was. I mean, physicians have known about aneurysms for millennia. Going back to the 2nd century AD, a Roman-era Greek surgeon named Antyllus actually pioneered a surgical treatment.
In the 2nd century?
Yes. His method was to physically tie off the blood vessel above and below the bulge with sutures, and then slice the aneurysm open to scoop out all the clotted blood.
Oh my God. Which is incredibly brutal.
Yeah.
But I suppose if the aneurysm is in your arm or your leg, tying off the vessel might save your life, even if you lose some circulation.
Right.
But you absolutely cannot do that to the aorta. You can't just put a knot in the main pipeline, delivering all the blood to the lower half of the human body.
No, tying off the aorta means the patient dies on the table. It wasn't until the 1850s that brilliant pathologists like Rudolf Virchow truly connected the microscopic dots between atherosclerotic wall damage and the formation of these aneurysms.
Okay, but even with that knowledge, they were kind of helpless, right? They could diagnose it, but they couldn't fix the aorta.
Exactly, which is what makes what happened in 1951 so mind-blowing.
Yes, Charles Dubost.
Right, a French surgeon. He performs the very first successful resection and replacement of an abdominal aortic aneurysm.
The patient was basically out of time, right?
Yes, and Dubost just cut the diseased bulging segment of the aorta entirely out of the body and replaced it with a homograft, which is a preserved segment of an aorta taken from a deceased donor.
That is an absolute watershed moment. The true birth of modern vascular surgery. And 1951. Think about that.
It's very recent.
That is literally within the living memory of our grandparents.
Yeah.
The fact that actual surgical fixes for a disease, this mechanical and this deadly, are that recent is staggering to me.
It highlights just how complex and delicate working on the aorta really is, but knowing how these aneurysms grow and how we finally learn to patch them brings us to a very difficult clinical reality today.
Which is how doctors actually manage these in real patients.
Exactly.
Wait, this is exactly where I have to challenge the logic of modern medicine based on what we just learned.
Okay, let's hear it.
Because the standard approach for a lot of these aneurysms today is just watch and wait.
Yes, it is.
But you just told me Laplace's law guarantees this thing operates on a vicious, compounding physical loop that literally cannot heal. Why on earth would the medical consensus be to just, watch and wait while a mathematical time bomb ticks inside a patient?
Look, it is psychologically agonizing for the patient to hear that. I agree.
Yeah.
But every time a surgeon opens a patient's abdomen, there is a very real risk of the patient dying from the surgery itself. The medical field has to balance the physics of the aneurysm against the trauma of the scalpel.
Okay, that's fair.
And there's a famous historical case that illustrates just how silently a patient can actually live with one of these while surgeons wait.
Are you talking about the Albert Einstein case?
Yes. In 1948, the pioneering surgeon Rudolf Nissen operated on Einstein for abdominal pain, and what he discovered was a pulsating, grapefruit-sized abdominal aortic aneurysm.
A grapefruit. Inside his abdomen.
A massive pressure vessel. And because Dubost's safe graft replacement technique hadn't been invented yet, Nissen had to use a palliative improvisational method.
Which was?
He literally wrapped Einstein's aorta in cellophane.
Like plastic wrap. Are you serious?
Yeah.
How does that fight Laplace's law?
Well, it doesn't fight the physics directly, it fights the biology. The cellophane was used to severely irritate the surrounding tissue.
Oh, to cause scarring.
Exactly, to induce a massive fibrotic scarring reaction. The body would build a thick capsule of dense scar tissue around the aneurysm, basically artificially thickening the wall to counteract the stretching.
That is wild.
And remarkably, it worked well enough that Einstein lived another 7 years with that grapefruit-sized time bomb silently coexisting inside him until it finally ruptured in 1955.
7 years of a ticking clock. That perfectly illustrates the watch and wait tension.
It really does.
Yeah.
Today, we know that for an abdominal aortic aneurysm, or AAA, the vast majority occur just below the renal arteries, the arteries that feed the kidneys.
Why always in that specific spot?
Because that lower segment of the aorta is naturally deficient in something called the vasa vasorum.
Vasa vasorum. What's that?
These are tiny microscopic blood vessels that literally feed oxygen to the walls of larger blood vessels. It's basically the plumbing for the plumbing.
Wow.
Because the lower aorta lacks a robust supply of these, the wall tissue is inherently more vulnerable to degrading.
So going back to my question of why we wait to operate on that vulnerable spot.
Right, so we have hard statistical data that dictates the timing now. Major studies like the UK small aneurysm trial and the American atom trial, they established our modern surgical thresholds.
And what are those?
The rule of thumb is to operate when the aneurysm reaches 5.5 centimeters in men and 5.0 centimeters in women.
Because before it hits that size, the math of the surgery is actually worse than the math of the aneurysm.
Precisely. Below 4 centimeters, the risk of that aneurysm rupturing in a given year is less than 1%. The risk of dying on the operating table or suffering a major complication is higher than that.
So you watch.
You watch. But once it crosses that 5.5 centimeter threshold, the radius in Laplace's equation gets so large that the physics take over dramatically.
Right.
By the time an aneurysm is above 8 centimeters, the rupture risk climbs exponentially to over 30% per year.
Terrifying. So we've talked about these massive pipes in the abdomen failing. But what happens when you take this exact same biological flaw and put it in a highly constrained, incredibly sensitive space, like the brain?
That brings us to those saccular berry aneurysms we mentioned earlier. They almost exclusively form at the base of the brain in an arterial ring called the circle of Willis.
And the plumbing analogy here in the notes made perfect sense to me. They form at T-junctions.
Yes.
Just like in a house, if you have high water pressure, the joints in the right-angled T-junctions take the most physical hammering, right?
Exactly. The blood vessels in the brain are hydrodynamically stressed in the exact same way. The blood comes rushing up the neck and just slams into these bifurcating junctions, slowly weakening the structural matrix over decades.
Wow.
And the statistics on these are staggering. Roughly 2 to 3% of the general population is walking around with one of these berry aneurysms.
That is a lot of people. Are those the only kinds of aneurysms you can get in the brain?
No, and it's a vital distinction. Berry aneurysms form on the surface of the brain at those major structural junctions. But there are also Charcot-Bouchard microaneurysms.
Microaneurysms.
Right. These are microscopic balloonings that happen deep, deep inside the delicate brain tissue. Think of the difference between a main water main bursting at a structural joint versus the tiny sprinkler pipes in your yard springing a pinhole leak.
And what causes the tiny sprinkler pipes to burst?
Chronic, unmanaged high blood pressure. But returning to the larger berry aneurysms, the overwhelming majority of people who have them will die of old age never knowing they were there.
But when they do rupture,
When they do rupture, they cause what's called a subarachnoid hemorrhage.
which is universally described by patients as a thunderclap headache, right? Like the worst pain imaginable coming on instantly.
That's the classic symptom, and the mortality is brutal. Between 30 and 50% of patients who suffer one will not survive the first month. We also know that the structural weakness driving these can be deeply genetic.
Yeah, the sources mention conditions like Marfan syndrome and Ehlers-Danlos syndrome. How do those rewrite the rules of the vessel wall?
Well, in a condition like Marfan syndrome, patients have a mutation in a specific gene called FBN1.
Okay.
This gene is responsible for building a protein that supports elastin. Without it, the body essentially builds its structural scaffolding out of faulty material.
It's like trying to reinforce a concrete wall with cheap plastic rebar instead of steel.
Perfect analogy. And in the vascular type of Ehlers-Danlos, A mutation in the COL3A1 gene means they produce defective collagen. Their structural steel cables are fundamentally brittle.
That's awful.
For these patients, aneurysm formation isn't just a localized problem, it's a constant systemic threat to every single vessel in their body.
So, what does this all mean? That ongoing biological failure reminds me of a massive surgical debate in the sources regarding how we treat abdominal aneurysms today. I want to talk about EVAIR and the massive twist ending hidden in the surgical data.
Ah, yes. The endovascular aneurysm repair debate. It has completely divided the vascular surgery community.
Right, so EVAIR sounds like absolute sci-fi magic. Instead of slicing a patient's abdomen wide open and clamping the aorta, surgeons make a tiny puncture in the femoral artery in the leg.
Just a small puncture, yes.
They thread a compressed stent graft all the way up into the abdomen using X-ray guidance and deploy it inside the bulging aneurysm like a ship in a bottle. The blood flows through the stent, taking the pressure off the diseased wall. It's far less invasive, and the recovery is incredibly fast.
It sounds perfect.
Right. But there is a huge biological catch.
There is. When you look at massive long-term studies like the UK EVAR trial and the Dutch DREAM trial, the early data is exactly what you'd expect. EVAR absolutely has a better early survival rate.
Makes sense.
Far fewer people die in the first 30 days compared to open abdominal surgery.
But then you hit the 8-year mark.
Yes. And over the long term, that early survival advantage entirely erodes and in some metrics reverses.
Wait, really? Why? I don't understand the mechanics of that. If the stent is acting as a brand new pipe, shouldn't the pressure be off the diseased wall permanently?
You have to remember that EVAR relies on a radial force, basically friction, to keep the stent wedged tightly against the healthy parts of the artery above and below the aneurysm.
Okay.
But the underlying disease, those MMP enzymes chewing through the tissue we talked about, that doesn't stop.
Oh, no.
The vessel wall around the stent continues to stretch and degrade over the years. Eventually, the vessel pulls away from the stent, or the stent loses its frictional grip and literally migrates down the aorta.
Oh, wow.
When that happens, you get what's called an endoleak. The highly pressurized blood sneaks around the edges of the stent and flows right back into the weakened aneurysm sac.
Unbelievable.
Because of this mechanical failure, EVAR patients face much higher rates of requiring a dangerous second intervention or suffering a late, unexpected rupture compared to patients who had the open surgery where the diseased pipe was permanently physically removed.
So a modern, less invasive procedure actually sets the stage for a worse long-term outcome for many patients because it doesn't solve the underlying biological decay. That is a brilliant mechanical twist.
It's a sobering reality in the field.
Speaking of things failing in unexpected ways, we need to clarify some major medical terminology and bust a few myths that surround this disease before we wrap up. First up in the notes, the mycotic misnomer.
Oh, this is a classic example of medical language calcifying and refusing to update.
Yeah.
Sir William Osler, one of the towering founding figures of modern medicine, coined the term mycotic aneurysm back in 1885. He used it to describe an aneurysm that formed because an infection had literally eaten into the vessel wall.
But if you know medical terminology, myco means fungus, like a mycologist studies mushrooms.
Exactly, but the vast majority of these infected aneurysms are not fungal at all. They are caused by common bacteria like Salmonella or Staphylococcus invading the bloodstream.
So it's just the wrong word.
Completely wrong. Vascular pathologists have been trying to retire the term for decades, begging the field to just call them infected aneurysms, but the term mycotic stubbornly persists in textbooks and exams to this day.
Wow. We also need to clear up what an aneurysm is not. Aortic dissection versus an aneurysm. They sound similar, but mechanically they're entirely different events, right?
Completely different. As we've spent this entire time establishing, an aneurysm is a stretch and bulge process. All the layers of the wall are intact, just ballooning outward.
Right.
A dissection is a catastrophic tear and split process. In a dissection, a microscopic tear happens on the innermost layer of the vessel, the intima.
Okay, the inner layer tears.
Yes. The pressurized blood gets caught in that tear and physically forces its way between the layers of the wall, peeling them violently apart like layers of cheap plywood.
So a perfectly normal-sized vessel can dissect without ever being an aneurysm first.
Correct. Though having a pre-existing aneurysm does stretch the tissue, which raises your risk of a dissection happening. This raises an important question, though, about screening.
Right. If these things are completely silent ticking clocks that operate on ruthless physics, shouldn't we just be giving everyone an ultrasound to find them?
You'd think so, but it raises an incredibly important question about the reality of population health statistics. Ultrasound screening absolutely works for one specific demographic, which is older men who have a history of smoking.
Okay, so they get screened.
Yes, it drastically reduces their aneurysm-related mortality, and the U.S. Preventive Services Task Force formally recommends a one-time screening for that group.
But the debate is over women and people who have never smoked, right?
The debate is fierce. The hard statistical reality is that abdominal aneurysms are roughly 4 to 6 times less common in women than in men.
Oh,
So population-wide screening becomes a mathematical inefficiency. You would have to scan thousands upon thousands of healthy women just to find one dangerous aneurysm. It's a constant, difficult argument about where the line of, worth the cost and anxiety actually sits.
let's bust two final misconceptions. Number one, aneurysms are not just in the brain or the chest.
Yay. Pop culture loves the dramatic brain aneurysm trope, but the aorta is responsible for by far the largest burden of aneurysm-related death. And there is a distinct third category, peripheral aneurysms.
Where are those?
The most common of those is the popliteal aneurysm, located in the artery right behind your knee. Interestingly, those are often bilateral.
Meaning both sides.
Exactly.
Yeah.
Meaning if a surgeon finds one behind your left knee, you almost certainly have one behind your right knee as well.
Fascinating. And the final, most dangerous misconception. I'll feel it if it's getting bad before it bursts.
Completely false. The vast majority are entirely silent. There's no pain, no palpable mass, no warning sign. Waiting for symptoms often means waiting for the physical rupture itself.
So as we pull all of these biological and physical threads together, what is the ultimate takeaway? Like, why is it so crucial that we understand the mechanics of these expanding pipes?
If we zoom out to the bigger picture, a ruptured abdominal aortic aneurysm has an overall mortality rate of somewhere around 80 to 90%, if you include the immense number of people who never even make it to the hospital.
That is just a staggering number.
It is one of the most lethal, catastrophic emergencies in all of modern medicine. Yet it is also one of the most perfectly preventable. A simple 5-minute painless ultrasound can catch it years before the physics take over, and an elective planned repair carries just a tiny fraction of that risk.
Right.
Aneurysms are essentially a public health bellwether. They sit exactly at the intersection of our aging population, the long-term biological effects of smoking, and the systemic damage of hypertension.
Well, I want to thank you, the listener, for providing such an incredible, detailed stack of sources. You perfectly illustrated why the human body is this amazing, delicate, and, sometimes terrifying pressure vessel.
It really is. And I'll leave you with a final thought to mull over, building on everything we've explored today.
Let's hear it.
We've talked extensively about Laplace's law, how a stretching biological pipe is mathematically doomed by physics to keep stretching because the tension perpetually increases.
The vicious circle.
Exactly. But what happens in the near future if we develop synthetic vessel replacements or advanced nanotherapies that can dynamically alter their own physical thickness?
Oh, wow.
What if we engineer a smart surgical graft that actively senses the blood pressure rising and physically hardens to push back against it, completely rewriting the rules of that vicious mathematical circle once and for all?
We started today by comparing the body to house plumbing, expecting our pipes to stay the exact same shape passively. But maybe the internal plumbing of the future won't just sit there and take the pressure. Maybe the pipes of tomorrow will finally learn how to fight back.